It's an absolute pleasure to have you all here today with us, and I wanted to warmly welcome everyone. I wanted to start by acknowledging the traditional custodians of the unceded lands from where we're all gathered today and where much of this research has taken place. We pay our respects to the elders, both past and present, and to all Aboriginal and Torres Strait Islander peoples. We also acknowledge that trans people are ancient. These lands are the home of the oldest continual culture and therefore the home of the oldest examples of gender diversity. So just a brief content warning. We're going to talk about some sensitive topics. We're going to talk a bit about mental health, including suicidality and discrimination. And so if you need to take a break, please feel free to step out, or if you scan this QR code, you'll find a whole range of support services here. This is what we're going to talk about today. We're going to give you a bit of an overview about our research group, share some of our highlights, and I've got several team members joining me today: Sav Zwickel, Sasha Bailey, Lockie Angus, Brendan Nolan, and then we're going to open up to any Q&A at the end. So who are we? We're based at the Department of Medicine at the University of Melbourne. We are a team of about 16 to 18 staff and students, and we really started the research group to address the huge clinical need. There was a great demand for knowledge about trans health. We also wanted to address the huge health inequity that many of you know that the trans community experience, and also the fact that there was very little research evidence to guide clinical care of trans people. And so we've sort of grown over the last 8 years, and now we're really driven by community need. Over half of our team are trans people themselves with lived experience. And so we co-design all of our projects to focus on sort of three main priorities. The first one, mental health and well-being. The second one, how to improve health service delivery. And the third one, because I'm an endocrinologist and several of us love hormones, we do a whole lot of research to better understand how do we best give gender-affirming hormone therapy and what the long-term effects are. And so we want to translate a lot of this research back into community. So we focus a lot on science communication, and every one of our projects aims to improve the health and well-being of the trans community. So we've chosen a couple of projects today to share with you because we've had quite a few highlights. In the last 12 months, we've published over 20 peer-reviewed publications. We've published 9 research blogs to try and make our research more accessible in everyday language for the community. We've overhauled our website. You can check it out at the web address at the bottom of the slide. And we've expanded our team, and we've been very, very grateful for several grants and awards. So to kick us off, I'd like to introduce Dr. Sav Zwickel. And Sav is going to talk about one of our projects that was published in the International Journal of Transgender Health, the met and unmet need for medical gender affirmation in the Australian non-binary community. Thanks, Sav. Over to you.
Thank you so much, Ada. So just to provide a little bit of background and the aims of what this project were. So there's this lingering kind of assumption in some areas of the community that non-binary people do not or very rarely pursue gender affirming hormone therapy or gender affirming surgery. And so this can have a roll-on effect in terms of creating additional barriers for non-binary people when they go to access hormones and surgery compared to trans men and trans women. So what we wanted to do with a community of sample of non-binary people living in Australia, we wanted to explore their rates of desire for and access to hormones and surgery, as well as met and unmet need for those as well. So we ended up with a sample of 271 non-binary people from across Australia who completed the survey between June 2021 and April 2022. And these participants ranged in age from 16 to 68 with a median age of 28 years. Now, we made a decision to look at this sample, dividing them up by the sex that they were presumed or assigned or recorded at birth. And part of the reason we did this is because when we did so, we actually found quite marked differences between the two groups. And we felt that if we were to combine everyone and just say non-binary people, we were losing some of that nuance. And we saw quite a difference. Those people presumed a female at birth. We had over 200 participants compared to only about 50 people presumed male at birth. And so even you can see here with some of the language that people use to describe themselves, some differences, with non-binary being the most common across both groups, trans being very common, trans masculine in the people presumed female at birth compared to trans feminine in the presumed male at birth. So firstly, looking at interest in or access to gender-affirming hormones in those non-binary people presumed female at birth. So we found that almost half, 49%, were currently using hormones at the time of the survey. In this case, it was testosterone in all examples. Another 9% had previously but not currently using hormones. And we didn't explore exactly why that was. So for some people, that might be that they have experienced barriers to care and can no longer currently access hormones. But for others, it might be a quite deliberate choice in that they've used hormones for a time and then feel like it's no longer part of their gender affirmation goals. And 6% were taking steps to commence hormones. Only 15% of this group expressed no interest in hormone therapy. And then when we looked again in people presumed female at birth and their interest in or history of gender-affirming surgery, we found 30% had had one or more type of surgery. For the vast majority, that was top surgery, double mastectomy. But a further 23% wanted surgery in the future. And so we've categorised that as total need for surgery being 53%. And about 17% said they had no interest in surgery. Then when we turn to the people presumed male at birth, 59% were currently using hormones, so that's a little bit higher than those presumed female at birth. 8% had previously but not currently used hormones, and 11% were taking steps to commence hormones, and only 6% said they had no interest in hormones. And so we can categorise all those who have ever used hormones or want to as total need at 78%. Then when we look at gender-affirming surgery, only 6% of those presumed male at birth had had any kind of gender-affirming surgery. So that's quite a bit lower than presumed female participants. But 26% wanted surgery. And so there's a total need there for about 32%, or 1 in 3 people presumed male at birth wanting or having had surgery. And about 1 in 5, 21%, said they had no interest in surgery. Almost half were actually contemplating whether surgery was something that was right for them, and they hadn't made a decision yet. So what we've done here is taken all those people who were categorised as having need for hormones or surgery, and then looking at met need for that versus unmet need. So you can see in the first column there, people presumed female at birth, 91% of those who wanted had been able to access hormones. So that's really great. It means there's quite a low rate of unmet need for hormones. In terms of surgery, though, a much more even split between people who want surgery and those who've been able to access it. We see in the third column, people presumed male at birth, 85% met need for hormones, 15% unmet need. And then lastly, surgery in people presumed male at birth, 82% unmet need. And so one of the things we can hypothesize here about that difference between the two groups around surgery is a cost being a main barrier for people. Top surgery as the most common type of surgery in people presumed female at birth, being a little bit cheaper than, say, genital surgery for people presumed male at birth. So just to wrap up the key findings here, really contrary to that common assumption that non-binary people don't want or are rarely accessing medical affirmation, this study really clearly showed that over half of non-binary people have ever used or want to use hormones, and 1 in 2 people presumed female at birth 1 in 3 presumed male at birth had or want gender affirming surgery. And so these findings can be used to inform non-binary people about diverse gender affirmation options that are available to them and to educate clinicians to improve individualised approaches to care, and obviously to advocate for greater access to gender affirming surgery in Australia. So I'm going to now pass over to my colleague, Sasha Bailey.
Thanks, Sav. Today we'll be presenting on a recent study that we did in 2023, looking at experiences of sport and physical activity among trans folks in Australia, related mental health outcomes and barriers and facilitators. But just for background, there's a lot of rhetoric currently and has been about trans people in sport, and notably trans voices are missing. There's little research examining trans people's firsthand experiences of sport and fitness participation. And to that end, we recruited a community sample of trans folks and aimed to explore barriers to participation in sport and fitness, and the mental health benefits afforded by such participation. So this is descriptives of our sample. In total, we were really, really lucky to reach over 600 folks. 1/3 trans men, about 1/3 trans women, about 1/3 non-binary, with a median age of 32. And again, fortunately, we had representation relatively from all Australian states and territories. So these internal barriers we derive from the literature, but also added a few based on lived experience, but also our community partners, Pride in Sport and Proud to Play. And we found that over 4 in 5 trans people surveyed reported facing any internal barriers to sport and fitness participation, among the most common being anxiety about others' reactions and body dissatisfaction or dysphoria. But as you can see, common reports were found for many barriers. Inversely, with external barriers, we found that over half of our sample reported experiencing any one external barriers, and most commonly, reports of inadequate bathroom and changing facilities were significantly prevalent, as were exclusionary rules and regulations surrounding gender, which participants reported deterring participation and uptake of sport and fitness. And rounding out the barriers and facilitators, we thought it was also important to hone in on the perpetration of gender-based bullying, discrimination, and exclusion. And we asked broadly experiences of those, but across a range of potential perpetrators. We found that over 1 in 3 trans people reported these adverse experiences in sport and fitness settings. But as you can see, the distribution of these incidents is quite spread across a range of perpetrators. And that likely owes in part to team sport environments versus individual sport environments versus more autonomous fitness settings like gyms and other similar recreational settings. And so this model was really the big aim that we set out to do, to test the association of regular sport and fitness participation with key mental health outcomes, namely psychological distress, recent suicidal thoughts, and recent suicide attempts. And unsurprisingly, as is well established in cisgender population literatures, we found that regular participation was associated with significantly reduced levels of psychological distress. It was associated with reduced odds of recent suicidal ideation, and also associated with odds of recent suicide attempts. These models accounted for a range of covariates, including whether or not folks were on gender-affirming hormones at the time. To wrap up, the headline findings, I suppose, that we found were that there were very low rates of sport and fitness participation among trans Australians that we found in this sample. About 1 in 3 um, folks regularly participating compared to about 78%, relatively comparable in the mainstream cis population. Um, there were prevalent reports of unique trans barriers to participation, but notwithstanding, we found that regular participation was associated with significantly lower psychological distress and odds of suicidality. And these findings really tell us that adequate bathrooms, inclusive gender rules, and affirming sport policies are promising solutions to facilitate participation. And these findings underscore a clear and vocal commitment, a need for that from sporting bodies to promote trans inclusion in community sport. Thanks.
All right, good morning, everyone. My name is Lachlan Angus. I'm an endocrinologist based in Adelaide, and I've been working my PhD from 2020, focusing on anti-androgens. So anti-androgens, sometimes called testosterone blockers, are medications we use to reduce the production of testosterone or sometimes reduce the effects. And there's a few ways we can do this. So commonly drugs will work on your pituitary gland, which controls the testes to try and switch off the signal for testosterone production. Or sometimes these medications work to block what we call the androgen receptor. So if you look at my diagram on the right, you can see on the left-hand side, a little blue square refers to testosterone, which binds to the androgen receptor and usually causes some changes. Some of the medications, such as spironolactone and cyproterone, which many of you will be familiar with, actually bind to the receptor and block testosterone from binding. So we call this androgen receptor antagonism. So we know from previous studies that, for example, cyproterone is more likely to cause lower testosterone levels. But until this study, we didn't actually know whether there was any difference in clinically meaningful outcomes, such as breast growth and body composition. So the aim of this study was to compare the effects in people newly starting estradiol and are randomized to treatment with either spironolactone or cyproterone. So as part of this randomized clinical trial, we recruited people aged 18 and over who were newly commencing estradiol, who had not previously used anti-androgens. And they were treated with either spironolactone 100 milligrams daily or cyproterone 12.5 milligrams daily for 6 months. And the outcomes we were particularly interested in was breast growth, gender dysphoria, and also testosterone levels. We did a few measures of breast growth, but the one that I think is the most robust is what we call estimated breast volume. And we did this taking some photos and then using a algorithm to calculate the breast volume. And you can see in the graph that spironolactone is in the green and cyproterone is in the yellow. And over 6 months, there was no difference in breast development between groups. However, interestingly, when you look at the changes in breast volume over time, you can again see in the yellow those treated with cyproterone and in the green those treated with spironolactone, there was really significant variation. So we had some people who had almost no change in breast volume over 6 months, while others had almost 500 mils, which is really significant. So we did this study between 2020 and 2022, and we had 63 participants split between groups, median age 25 years and median BMI of 27. And the breast development that we noted equates to a mean cup size of AAA, which is less than would typically be seen in cisgender girls going through puberty. And what we did also show was that there was perhaps a very weak association with high estradiol levels and increased breast development. And this is something we want to explore further. When we look at gender dysphoria and also depression, we assess this using some questionnaires. So firstly, the GPSQ, or the Gender Preoccupation and Stability Questionnaire, which asks questions about feelings of gender-related distress over the previous 2 weeks. And a score on this questionnaire of 28 or greater indicates significant gender dysphoria. So you can see in our population at baseline, there were significant rates of gender dysphoria, and we did see a trend of this improving with time at commencement of hormone therapy. However, there was no difference between groups. And additionally, when we look at depression, we use another questionnaire called the Patient Health Questionnaire 9, which asks about symptoms related to depression over the preceding 2 weeks. And a score of greater than 10 indicates moderate to severe depression. And if you look at this, you can see we had relatively high rates of depression amongst both groups, but again, no significant change over time. Now, this finding, I think, is somewhat reassuring, given some of you may be aware that cyproterone has been linked to mood disturbance and worsening of depression. However, it's also a little bit disappointing in that we hoped that commencement of hormone therapy might have resulted in greater improvement in depression over the 6 month time. Now, finally, when we look at testosterone levels, so we knew from previous studies that suppression of testosterone was more likely with cyproterone compared to spironolactone. And sure enough, in our study, you can see that the separation between groups becomes very apparent quite early, even at the 1 month mark. So certainly cyproterone was much more likely to suppress testosterone. However, at 6 months, the change is overall fairly similar between groups. And I guess what I want to kind of highlight here is even though guidelines recommend suppressing testosterone to the female range, typically less than 2 nanomoles per litre, we've shown from this study that the outcomes in terms of breast development were pretty similar. And so I think we probably need to be a little bit more nuanced with what we target with our treatment. So in conclusion, from the 6 month trial of spironolactone versus cyproterone in people commencing estradiol, we showed no difference in breast growth, gender dysphoria, or depression. Cyproterone was more likely to suppress testosterone than spiro, and as such, we think the anti-androgen choice should be based on consideration of different side effects and patient preference. And now I get to hand over to Dr. Brendan Nolan to discuss his study related to testosterone and quality of life.
Thanks, Lockie. So my name's Brendan. I'm an endocrinologist and a research fellow in the Trans Health Research Group. Today, I'm going to be talking you through one of our studies evaluating the impact of early access to hormone therapy on quality of life outcomes in trans people newly initiating testosterone. So I guess one of the things that we are wanting to look at is the mental health impact of early access to hormone therapy. And we all know that unfortunately there can be quite long wait lists at clinics throughout Australia. So we, a few years ago, designed a study to look at the impact of giving people earlier access to hormones, and this is testosterone in particular, and showed that early access to testosterone reduces gender dysphoria, and it resulted in clinically significant improvements in depression and suicidality in trans adults. As a secondary outcome of the original study, we were also looking at quality of life. And there have been previous studies that have demonstrated associations between commencement of testosterone and improved quality of life, but no previous studies have used a randomized controlled trial design, which is a superior clinical trial design. So the aim was to evaluate the impact of early access to testosterone compared to a standard care waiting list on quality of life. So this diagram shows the study design. We recruited trans adults aged 18 years or older seeking to start testosterone therapy. So following a clinical assessment with myself, and we utilised the informed consent model of care, people were randomised to either immediate testosterone, that means commencement of testosterone within a week or two of the first visit with me, or they were randomised to a standard care wait list. When we designed the study at our clinic in Melbourne, the standard care wait list was about 3 months. And so we essentially used that as a standard care control arm, and everyone had their visit with me at month 3. People were able to choose between testosterone injections or gel as per standard care. And they completed questionnaires relating to quality of life at baseline and at month 3. We evaluated quality of life using EQ5D5L, which is just one of the standard quality of life measures. In the figure on the left, you can appreciate that there's 5 individual domains within the quality of life measure: mobility, self-care, usual activities, pain, and then anxiety and depression. And participants rate their quality of life and difficulties related to each of these domains on a scale from 1 to 5. They're then all joined together with a fancy formula that gives you an overall score called the utility index. The second component for the EQ5D5L is the visual analog scale. That's essentially a 0 to 100 scale where participants are able to self-report their health at that point in time, where 100 is the best health you can imagine and 0 is the worst health you can imagine. So this table here just demonstrates the two main outcomes. One is the utility index, which is the fancy calculation. The summary of that is that there was an improvement in the overall utility index in the group who had early access to testosterone. However, when we compared that to the group who were waiting 3 months for testosterone, there was no between group difference. It didn't reach what we call statistical significance. However, when we look at the visual analog scale, so that's the 0 to 100 scale, the yellow line are people who had early access to testosterone. The dotted pink line are people who had testosterone initiation at 3 months. You can appreciate that there was quite a significant improvement in the 0 to 100 scale at 3 months with early access to testosterone. The between group difference was 11.6 points over 3 months. And so, although we haven't used this questionnaire in the trans population before, that sort of range is what we would normally consider to be a clinically significant improvement in quality of life. So I think this is very meaningful data from that perspective. So as mentioned, we demonstrated a clinically meaningful improvement in self-rated health using the VAS, the 0 to 100 scale, but the change in the overall utility index did not reach statistical significance. And I think that's potentially because we had a relatively young and healthy cohort of people. And so a lot of the scores for, say, mobility or other self-cares were actually fine at the start of the study. So we're not necessarily going to see an improvement if there's nothing to improve in some of those dimensions. And for that reason, it's probably not the best questionnaire and hasn't been validated in trans people. And I think we still do need some further long-term research looking at quality of life outcomes. Thank you.
Thank you, Brendan. So what are we up to next? As I mentioned at the beginning, we've got 3 main research priorities, mental health and wellbeing. We're doing a further mental health survey that we're repeating every 2 years. We've got data from the last 6 years now. We're looking at the impact of the anti-trans media and the anti-trans rhetoric on the community, as well as on housing and the impact of housing and housing insecurity and employment and unemployment on the community. We're doing some further work to try and strengthen sporting participation. Regarding health service delivery, we're evaluating the informed consent model of care and also evaluating a peer support training program for people waiting for care. We have a MRFF grant to look at a new shared care model of care to access gender-affirming hormone therapy for people living in rural and remote Victoria. There's a whole range of studies happening trying to better understand and better optimize gender-affirming hormone therapy delivery. We've got studies looking at how does hormone therapy impact on fitness and muscle strength, or heart health and bone and muscle. We've also got studies looking at how can we prevent hair loss in trans people who use testosterone therapy, and evaluating how low-dose testosterone, often for non-binary people, impacts on dysphoria and quality of life, as well as some research evaluating progesterone. So a core part of what we've been doing is trying to translate what we're finding in research into policies and programs that actually benefit the community on the ground. So we've been involved in sort of sharing a lot of our findings with a broad audience on social media. We've got an engaged following on Facebook and Instagram, and we're trying to keep our pulse on what the latest platform is. We've also updated our website to make it an accessible resource for not only community, but also healthcare professionals who may be looking for resources to support trans and gender diverse clients or patients. We've got a staff member looking after this, and he's done a fantastic job improving engagement in a lot of these resources. They also provide a site where you can access all of the latest research and participate in research as well. There's been a lot of engagement with our blogs, and this is probably our most popular blog, the one on genital changes, periods and pelvic pain, that's outperformed all of our other blogs by about 10-fold. But we keep trying to write blogs so that the information that we gain from research is accessible. We're also do a lot of speaking and presenting at various forums in corporate and in healthcare professional conferences and in health professional education events, just trying to make sure that the conversations is evidence-based and ensuring that we can get the latest research findings and get the latest professional resources out into people, into the community, and to where it's needed most. So finally, I just want to acknowledge all of you. Thank you for joining us here on this Zoom meeting today. But I also wanted to thank not only my fantastic research team, but also the huge number of trans and gender diverse people with lived experience who participate in our research throughout 2024 and beyond, our wonderful volunteers who are integral to our team, our community advisory group who provide invaluable feedback, and our many collaborators, including other research groups, community organisations, advocacy groups, researchers and clinicians. And I also want to thank our funding bodies, because we actually can't do any of our work without research funding. So we're very grateful for the support from all the organisations listed. So thank you very much. We're open to any questions. You can find out more information on our website here, and you can access it via this QR code as well.
You should have access to a Q&A icon at the bottom of your screen where you can send through some questions. They can be anonymous if you want. And we're happy to answer them to the best of our ability. A few questions coming through. So the first one is, if folks within the sector would be interested in collaborating, what is the best way to reach out?
I think the best way to reach out is via email. You can contact us on gender-research@unimelb.edu.au, and Sav's just entered it into the chat. We'd love to collaborate on to work together and achieve our shared goals. So we'd love to have conversations.
Question for Brendan. I wonder what other measure you would have used, or whether a fit for purpose one is required.
It's a good question, and one that we've had a lot of conversations about amongst ourselves. I mean, I think it's probably not the best measure that we've got. There are a variety of quality of life measures used in the general population, but none of which are probably directly applicable to what we're hoping to show with our cohort. There is one trans-specific quality of life questionnaire that I'm aware of, that two of us had a chat about this morning, but it probably also isn't the best measure and hasn't been validated in a large cohort of people. So I think there's still a lot of work that we've got to do. We've previously also used SF36 in some previous research, but unfortunately there's limitations to pretty much all of the quality of life questionnaires.
As Brendan mentioned, we've had lots of discussion about what's the best way to measure quality of life, because the existing tools ask about things that aren't necessarily relevant, often pain or mobility, or a lot of the quality of life questionnaires are designed sort of for elderly population. So if anyone has any suggestions on what would be a good quality of life outcome measure, please let us know your thoughts. We'd love to hear them.
We have a question from Cade. So it was for Sasha, but Ada and I were also involved in that study, so we can chip in. So wondering, is there any insight into differences with sport participation for trans and gender diverse people in terms of regional versus major cities? So we did actually collect, I think from memory, postcode for participants. We haven't run that analysis yet, but that would be that's a great suggestion and something we could definitely look into. We've got quite a lot of data from that study still that we have yet to go through, including like a lot of free text qualitative responses. So there's at least probably 2 publications to go, but we'll definitely have a look at that and see what comes out as far as that goes. Yeah. Well, thank you, everyone. I really appreciate your attendance today. And we always love the opportunity to share what research we're doing, and to be able to communicate it in ways that, are more accessible to as many people as possible, be that trans community members or stakeholders, clinicians, etc.
Thank you everyone for coming, and have a good afternoon.